Well, hey everybody, this is Robert, and welcome to today's live stream. And it's going to be on monkeypox, something that's really saturating the news right now. But there's a lot of unknowns and a lot of questions concerning this very unusual situation that's going on around the planet. Now, if you have followed the Infectious Disease News Facebook page or the Outbreak News TV YouTube channel, or of course the OutbreakNewsToday.com website, you've been exposed to information about monkeypox for years because I've been covering it for years. So May 2022 is not something new to you, but there's a lot of people, this is the first time they've ever heard of monkeypox. And there's a lot of mystery and questions about it. And now that monkeypox is really a household name as more and more cases are discovered across the globe. The European CDC said today that the total is more than 700 cases on several continents. So, yeah, there's a lot of it going on right now. Now, in today's live stream, I'm joined by a friend of the show, Texas State University's own Dr. Rodney Rohde. You may remember him from the rabies live stream we did several months ago. And he recently published an article on the conversation entitled, "What is Monkeypox? A microbiologist explains what's known about this smallpox cousin." So today, you and I are going to pick his brain. So please welcome Rodney Rohde, PhD. Dr. Rohde, welcome back to the program.
Good afternoon, Robert. Thanks so much. As you know, for me, this is always an honor to talk with you and to share, some information, and hopefully we can get the information out there that's calming and not a panic-inducing. Because as we know, science communication is so critical in today's world. So thank you for having me on your show.
Absolutely, yeah. We definitely need some clarity on all this. So, Dr. Rohde, let's go ahead and start by building a foundation with some background. What is monkeypox? And what do we know about the history and the geography prior to this current situation?
Sure. So yeah, let's kind of back up and talk about the virus itself, since everybody's focused on this current 2022 thing going along. But as you mentioned, it's not brand new. In fact, many would argue that monkeypox virus has been around for millennia, not just decades. So they belong to a group of viruses called the orthopox viruses of the Poxviridae. So the Poxviridae is the family, orthopox is the genus, and that includes monkeypox virus, and that's the causative agent of monkeypox. And I think some of the interest around this topic is that monkeypox also includes other viruses that people are aware of, such as smallpox, which certainly has history behind it, and sometimes some terrifying history, as well as cowpox and some other things. So it's in that same genus, and so I think that's probably what often will get people talking about it. It's monkeypox, like many of these, are zoonotic in nature. So while we don't just absolutely know the animal reservoir, when you look at that research literature, most people do believe that it is rodent borne. Interestingly, it's not from monkeys. It was given that name because one of the first known outbreaks in 1958 or so came from a shipment of monkeys that were being used for research. So it kind of got that moniker, and it really is a misnomer. It's probably could be referred to as rodent virus more than monkey virus. But anyway, that's kind of where the history comes from it. And there's really two clades. I know we might talk about this later, but the two clades of virus are called West African monkeypox and Congo Basin monkeypox. And that second one, Congo Basin, can cause up to 10% mortality. And the West African clade is only about 1%. So there's a range from about 1 to 10% mortality, nothing like smallpox. And so I'll kind of stop there for a second in case you have any follow-up questions, but that's kind of the big picture behind kind of the virus itself.
Yeah, and concerning the clades, Dr. Rohde, I mean, just for people that aren't familiar with that term, what does that exactly mean? Is that a strain, a type from a common ancestry? What does
Yes.
that mean?
Yes, great reminder. I need to define my jargon here. So clades are typically used when you're talking about nucleic acid sequences primarily. And so this is a genotype. And so there's two primary genotypes that kind of fall out of that monkeypox virus, the West African clade and the Congo Basin clade. And then when you're doing sequencing of these different isolates that show up in patient cases, what epidemiologists and ultimately physicians and other researchers are trying to find out is, can you use that sequence-based typing to help identify perhaps the origin or the spread or just kind of the history of that case by looking back. It's very much like we do with food outborne outbreaks. You're trying to find kind of that index case, and then where does it fall out when you're looking at different cases. So it's really an epidemiological tool more than a medical tool. Medical tool is more, is it just positive or negative, and let's treat or do something about it. It's more of a tracking tool.
Now, as far as the geography prior to May 2022, it's primarily confined to a handful of countries in Africa, with a few exceptions. Can you talk about that?
Yeah, so it's known to be endemic in several Central and West African countries. I don't have all of those at my fingertips, but that's the primary thought origin of really most of these outbreaks. Really, most times that we've seen this disease arise in other places, like in the US or Europe or things like that, most of the time it's linked to travel to those areas. And so part of one of the interesting things around this outbreak, as you know, is that that hasn't been consistently the case. There have been clusters and people kind of popping in and out of different countries, and they're doing that. That's still kind of an ongoing epidemiological study looking at that to see, really what's going on with this clade as compared to, say, back in the big Nigeria outbreak in 2017, 2018. There was a lot of cases that kind of was primarily travel based. So just a little different this time. And I think between that and the transmission routes is probably what has, most people very interested in following this, as we should be.
Yeah, and you actually disclosed something to me prior to coming on air, that you actually have a little bit of experience with monkeypox about 2 decades
Yeah.
ago.
Yeah. Thanks for the
And
reminder. So when I
what's the
was,
story behind that?
yeah, when I was working for the Department of Health in Austin, right out of my master's program in virology, I was working for the Zoonosis Control Division, which we've talked about before when we've discussed rabies.
Hmm.
But it was all types of zoonotic disease. And one of the first things that I got thrown into, so I started in '02. In '03, if you follow the literature on monkeypox, you'll know that there was a kind of a travel translocation based issue with monkeypox that came out of Ghana and actually ended up in Texas and some other places. And the concern was that there would be transmission within prairie dogs in Texas and other types of rodent based animals. So we were out doing some collections and really early molecular work, PCR based work, to try to identify that spread of those different animals. So that was an interesting kind of introduction to the world of zoonosis, kind of outside the realm of rabies and things that I was used to.
Yeah. And if anybody wants to check that out, the CDC has a whole page on this.
Yes.
I don't know how many there were, 35, 40
Yes.
cases. Yeah. And so it was quite a big deal back then, if you're old enough to remember. Um, Now, when you mentioned this orthopox virus related to smallpox, cowpox, not related to chickenpox, though.
Yeah, chickenpox, varicella zoster virus, which is both chickenpox and shingles. That's in the herpes viridae family,
Mhm.
so a different viral family. Some people might think about the pustules or the sores, the vesicular lesions, the vesicles that you develop, that look like chickenpox, perhaps, but it's a completely different virus, completely different viral family, and certainly some similarities there, but it's not a chickenpox relative.
Yeah. Um, Let's go ahead and talk about transmission. I mean, prior to the current situation, when you'd hear a story about a cluster or an outbreak in Nigeria or the Democratic Republic of the Congo, it was typically related to exposure to an animal and or um, close contacts within a family unit. Can you give us some more detail about the transmission?
Sure. Just a little background. So typically someone, at least all the current information around this, is that someone is typically considered infectious from the onset of the illness, really until all those lesions that we talked about. And we can talk timeline here in a second if we want to, but eventually you develop lesions. Once those have crusted over and they've separated, and you start showing a fresh layer of healthy skin under that, typically you're thought to be not infectious after that. And as you mentioned, human to human anyway, transmission occurs primarily by direct contact with infected body fluids or lesions. It can occur with fomites, and so another word there that we use in the jargon way. But fomites can be things like linens or sheets, or even clothing, undergarments, things like that, and also can be spread through respiratory secretions. But that typically needs to be a really kind of longer interaction. For example, historically, there's a lot of documented human to human transmission when you have a group of people, say in a household, that are sharing a lot of time and housing area, including prisons or other places where people are just kind of closed in and they're not separated well. So that's the historical kind of look at that, Robert. And then when you look at this current outbreak, as we kind of transition perhaps over to that, what's I think really caught a lot of people watching this is, according, I mentioned this earlier, there's a new MMWR from CDC, Morbidity and Mortality Weekly Report that CDC puts out. There's 9 states now in the United States that we're watching with this outbreak, this 2022 outbreak. And they're really looking at, as of about May 31st, about 17 cases now in the United States. Now, again, they're investigating these. The primary one has been that original one in Massachusetts. But the other ones have primarily, 16 of those 17 cases, Robert, were in persons that were self-identify as gay, bisexual, or men who have sex with men, MSMs. And so they're really following that. And while no one has really stepped out and labeled this as a sexual transmission type of infection, certainly the suggestion is that really close person-to-person community transmission might be occurring from that type of high level and high number of people that have the infection. That I don't think anybody's ready to say yet that it's all of a sudden we're dealing with a sexually transmitted disease.
Mm-hmm.
The new nomenclature is STI, sexually transmitted infection, and it's probably more of the close, perhaps intimate contact between those individuals that is at least exhibiting these kind of unusual places that you normally wouldn't see pustules and lesions and things like that.
On the issue of transmission, Rodney, we have a question from Facebook, and Tiffany asked, "Is there an age group that's more susceptible?" Really good question.
That is a great question. Looking at the cases right now, I think the ages primarily have been in the young adult to middle age kind of group, especially within this 17 or so cases here in the U.S. that we're following. I am not certain if we look globally, as you mentioned earlier, Robert, they're following almost 800 cases now, to my knowledge, globally. And so there perhaps could be a different age range. It might be some younger, some older, but it seems to be in that young adult to kind of mid-age level, from my understanding.
And I would suspect, and correct me if I'm wrong, that people that are immunocompromised, people that
Yes.
are maybe very young.
Right. Right. In fact, I think in the U.S. we have the identification of those. 2 of them have self-identified as immunocompromised. So certainly that is, kind of a given in most of these cases when you have, whether it's age-related immunocompromised or, they are suffering from other types of disease or other conditions like COPD or diabetes or HIV or whatever the situation is, certainly more susceptible to developing more problematic disease.
Yeah. I want to get into signs and symptoms, but before I do, I'm going to link to Dr. Rohde's article when I publish the podcast. You'll see it in the show notes. I encourage you to check it out, and you can spend whatever time you need to go ahead and read over it. But he does go over transmission, signs and symptoms very thoroughly. So I encourage you to check that out. So, Dr. Rohde, what are the signs and symptoms of monkeypox? And you said there's, like many diseases, there's a timeline with the symptoms.
Yeah, it's a really important thing to talk about. Thanks again for linking and talking about my article in the conversation. I also did an article for the American Society for Microbiology about 4 or 5 days after that one. So there's a couple of them out there circulating.
Oh, definitely send me that link so I can put that up too.
I will. I'd be happy to. Thank you. So with respect to monkeypox, it unfortunately is a self-limiting disease. It typically takes about 2 to 4 weeks to resolve. And most data shows that the viral incubation is about 5 to 21 days. Again, that's variable with respect to when a person's going to start experiencing symptoms. They break it out into kind of stages, like many other illnesses. We have kind of a prodrome or early stage. Really nothing notable symptomatically, except that it's similar to other things. So as you've heard before, you get a lot of flu-like symptoms early on. You might have fever, you might have malaise, headaches, and muscle aches, and swollen lymph nodes and things like that. But after that, a few days later, you typically start developing this characteristic rash. Now, generally, here's what's, again, a little different than what we're seeing in this current outbreak. Historically, you tend to see it kind of showing up on the face, and then it tends to spread to other areas, including your hands. And so you see a lot of photos on publications with hands or feet, perhaps, that will have lesions, even on the palms or the soles of the feet. So that's a little interesting to see. And then they'll kind of go through just different stages. They'll start out as kind of flat, then they'll get raised so they're more convex, and you'll see them filled with pus-like kind of yellowish fluid. And then ultimately they crust over and end up in scabs, and those will eventually fall off. And so those types of symptoms, again, I think people, will link that to smallpox, and they do mimic smallpox, but they're way less severe. And as I mentioned earlier, they usually are self-limiting and they resolve, and most people recover without issue. However, just to make sure we all understand, there is that mortality rate, 1 to 10%. So the Congo Basin strain is the more virulent. It's about 10% mortality. The West African one is about 1%. And that's what we're currently seeing in the 2022 outbreak. Most of our sequence data and things like that, we're seeing this West African clade. So far, to my knowledge, as of the end of May, in the US, we're reporting just the West African type of clade. And so that's kind of where signs and symptoms fall out for this particular virus.
Yeah, and as far as the clade, though, I mean, in the DRC, for example, where they have the Central African clade,
right,
10% fatality. So they may have 50 or 60 fatalities so far this year, according to the latest numbers I saw. And Nigeria has 1 fatality this year, and they have the West African clade. But nobody's died out of this almost 800 people in the Western countries. How much of that is due to just a better healthcare system too?
Yeah, I absolutely would agree with you. I mean, like most things, it's always difficult, I think, for us to totally compare time periods. People, when we were talking about, still dealing with COVID, and trying to compare that to the big influenza 1918 to 1921, it's just different, right, Robert? I mean, healthcare, even though we complain about U.S. healthcare at times, it's still one of the best healthcare systems in the world with respect to treatment and diagnosis and follow-up and things like that. So certainly that plays a part in it when you're coming into more developed countries. Even diagnostics, right? I mean, we're so much better at diagnosing infections. We may have missed things decades ago, and we might have even missed fatalities for that matter. So I just think those are things we always have to consider and try to look at comparisons with context and kind of keep that in mind, because it's really sometimes apples to oranges when you're trying to compare time frames. It's especially without similar data, similar variables, and all the things that can go along with an outbreak.
Yeah, and I think another example would be measles.
Yes.
I don't remember the last time we've had a measles fatality in the United States, but in
Yeah.
Africa, there's measles fatalities
All the time.
all the time. Yeah, so I
Yeah.
mean that has a lot to do with the healthcare systems. There's no doubt. Um, so, Dr. Rohde, the signs and symptoms of monkeypox, you described them. If you're a physician in the emergency room, how would you differentiate that from smallpox? Was or chickenpox or shingles or any related vesicle producing virus?
Yeah. Yeah, that's a great question. And again, depending on, it kind of depends on what's surrounding the case. And so, certainly right now, after the May 17th confirmation of the Massachusetts resident that we now know, basically, again, maybe a quick comment about the testing. Primarily, the gold standard is really a DNA detection via real-time PCR, and they usually do that from lesion swabs. So they get into that pustule or that lesion with a swab, and they obtain some fluid, maybe scrape a little bit of the skin cells there, and then they put it into that real-time PCR test to confirm it. And that's what we did with the Massachusetts resident. And then we kind of advise physicians in ERs or anywhere else to make sure that first, if they're suspicious of monkeypox as a potential infection, that they contact. There's I forget it last count, Robert. There might be over 100 laboratory response networks now in the U.S. These are labs that are set up with CDC to do certain types of testing, way more safer. Instead of trying to do it in a hospital. Again, hospitals typically wouldn't be doing this type of testing because you don't have hundreds of cases of this on an annual basis. So this is a special test. And I think the last time I looked, there was about 68 of these LRNs, laboratory response network labs, that can do this testing, this rapid testing. So we do have that in place, and that's good.
So, Dr. Rohde, so what does the rapid test determine, whether it's an orthopox virus or
Right.
does it go all the way to monkeypox?
It goes all the way to monkeypox.
Okay.
Yeah. So that's a good point. So you can distinguish those between, say smallpox or cowpox or something like that. Now, this again, great point, Robert, and this as a medical lab person. Signs and symptoms are really important, and that's more of a physician-based, looking at the case, doing a full case history. All of that never goes away. That's always really critical and important, especially in these unique types of perhaps outbreaks. But you really do need a confirmation, a confirmatory laboratory test. And so that's what we can do with the real-time PCR test, is we can confirm it as monkeypox, so that we're not panicking and thinking we're having some type of, reintroduction of smallpox or anything else. We can absolutely kind of tie it down. But, going back to the cases and how they kind of present, we already talked about this kind of febrile flu-like symptomology in the first week or so, and then you get all these kind of typical muscle aches and fever, and then it will move on to these different rashes, and they typically are centrifugal distribution. What really is unique, I think, about this one is that usually those are on the face. They start showing up on the extremities. But really what's unique about these cases in 2022 is that they're atypical. And so the lesions have been in the genital and perianal region. They tend to not have any fever or other of these kind of prodrome symptoms. And so while there might be some confusion with things like varicella zoster or other STIs like genital herpes or even syphilis for that matter, That's part of the differential, is that if they are in these kind of different areas of the body, that's something that the CDC, they've already sent out a health alert, an HAN, a health alert network communication to all hospitals and ERs to kind of be looking for those differences. And then, absolutely taking a sample and having that sent through an LRN or the CDC to start confirming that particular infection, because we really want to get it right with a laboratory confirmation. And before that, of course, they might house that patient separately in quarantine and be very careful. The good news with this is it's nothing like SARS-CoV-2. It's not transmitted rapidly with aerosolization. It's a pretty low reproductive number. It's below 1. So something like measles approaches 20. So one person can barely transmit that infection to the next person, and it has to be really close contact, and it has to be, I think the recommendation is more than 3 hours. I mean, really close contact for a prolonged period of time. So it's just a little different, a little harder to spread. And we have the testing and the diagnostics in place right now. As you said, historically, we've been doing this for at least a couple of decades now. So we're really it's nothing like SARS-CoV-2. It's not a novel virus. It's something we are prepared for. We have history of testing. We have accurate tests. We have an antiviral. We have vaccines that work. And so it's just nothing like COVID-19. But certainly, I think it shows the world, again, that public health surveillance and medical laboratory testing is critical as we go forward and forever. To be prepared for these types of inductions of disease and different agents that are popping up.
Not only that, but just the awareness of zoonotic infections. I mean, we saw Ebola here at one time, right? We've seen Lassa here. I mean, granted they're travel associated, but you never know.
Yeah, I mean, you and we talk about this all the time, and those of us in this area know this, that animal health is absolutely directly tied to human health, as is the environment. And that's kind of this whole concept of one health. And so we must pay attention to the animal population as well as the human population, be ready to kind of try to find those links and do the genomic surveillance that we've really upped our game because of SARS in this pandemic. But what, getting on my soapbox a little bit here, as you know, I mean, we have to keep that. It's really easy to get lazy and we think we were kind of over a particular virus and you let your guard down. You really need to maintain at least a critical mass for testing and stuff, so that doesn't happen again, so that it's not all about the CDC. We need regional typing labs. We need professionals in place. We need equipment and other things ready to go, so that when these events occur, we can put out those panics and put out those fires way quicker than say SARS-CoV-2, when it was such a novel virus and we just really weren't ready for that.
Yeah. It's interesting too. If it's sticking on the subject of zoonotic infections, I think I read an article today that Nigeria just came out and banned bushmeat because of the monkeypox outbreak. And if viewers or listeners aren't familiar with bushmeat, that's eating bats and monkeys, right, and stuff like that.
Yeah, just stuff you don't think about maybe in the States, but certainly. But even in the States, Robert, we've seen time and again those people that interact with animals, both domestic and wildlife, in ways that you don't think that most people do this, but there are people that they're taxidermists, or they want to use a hide from anything from rabbits, right, that you can get different tularemia, or just all these agents. And again, it's not the mainstream medical worry, but when you interact with wildlife and with other types of animals, there's absolutely a zoonotic risk, especially if you're immunocompromised or you have other issues. So it's kind of an ongoing education process, and people I think people have learned a lot in the last 2 years, and this just follows it up. It's really interesting that it happened, right now in this time frame when everybody's kind of getting a little bit calm from COVID, and now, whoa, what's going on with monkeypox? And it's not a scare tactic, but it is a good reminder that we need to be on alert at all times for these types of things.
Yeah, it's funny. I can recall when I first started the website back in 2009. One of the first stories I covered was anthrax outbreak in New Hampshire, and what they were doing is these people were making drums, and they were using animal skins for
Yep.
it, and the animal skins were coated with
Yep.
anthrax spores. So I mean,
You
who
just
would have
never
thought?
know, right? You just
Yeah,
never
that's,
know.
that's something, right? Um, I just want to go back to one more question, Dr. Rohde, because I'm not sure if it was addressed. Um, if an individual shows up to the emergency room, the ER doc, is he or she going to be confused with differentiating monkeypox from chickenpox, for example, something that's incredibly common?
There again, I can't speak from a physician standpoint,
Hmm.
but there are some similarities,
Yeah.
especially in the pustules and things like that. It's just that chickenpox, for example, tends to just cover the body generally, not always, but generally. There are subclinical, and I mean, there's all these exceptions, of course, but chickenpox looks different. They tend to not show up, just in specific areas like the face and the hands and the feet. And so there are some early signs if you're paying attention. But again, that's why that test is so critical, because you can get that test turned around pretty quickly, including a physician can order a testing for chicken pox or shingles or something like that and get a pretty good turnaround on that as well,
Hmm.
probably quicker than monkeypox. So you certainly could rule in or rule out chicken pox, herpes, syphilis, those types of things, maybe even other types of rash-based diseases that we might not be covering today. But those are all usually either antigenic or PCR based and pretty quick to rule out.
Not only that, I would suspect that ER physicians around the country have got a deep dive of training in recent weeks
Yes.
on monkeypox symptoms, right?
Yeah, that's that. I think that's the good piece again. I know CDC's had some rough months in the last couple of years, but
Mhm.
what I always appreciate about them is they send out the HAN
Yeah.
alerts, and you're familiar with those, and they
Yes.
specifically target hospitals and ERs and even private facilities to be on the lookout for these types of things and how to handle that sample to get it tested. So that we're pretty good at, as far as my understanding is and how it works.
Okay, let me go to another question. Again, it's Tiffany. She got another great question. Um, for those diagnosed, is there a quarantine period in hospital or home, Dr. Rohde?
Yeah, there's kind of some, how should I say it, kind of conservative ways to kind of handle this if you're concerned with it. So typically, my understanding is that once you have a confirmation, of the disease, and they're done that history, and they've got that laboratory test kind of locked in, they're typically going to ask you to isolate that ill person from all uninfected persons. So that's just kind of the first foundational thing they're going to do. But kind of the general stuff that we're all aware of. They're going to ask you to practice good hand hygiene, from the medical side, and, use appropriate personal protective equipment to protect household members if you're ill or caring for ill persons at home. For example, a good surgical mask that we've gotten used to during COVID, long sleeves, pants, disposable gloves are useful. And there's even a recommendation to use a particular registered disinfectant that's good for emerging viral pathogens. It's on the EPA's list Q, as in Queen, for disinfection of surfaces. So even though that's unlikely, there can be this fomite transmission with surfaces and things like that. And then anyone that's infectious, they are considered to be infectious. They should avoid contact with pets and other animals because sometimes other mammals might be susceptible to monkeypox. Again, kind of rare. And really, They should avoid close contact with others, including intimate or sexual contact, until they are confirmed or ruled out. And my understanding is that basically you're going to go about 7 to 10 days after those lesions and scabs have kind of fallen off and you've got healthy skin. And so kind of give that about a 7 to 10 day period to kind of rule out any further possibility of transmission.
Yeah, I mean, what I've seen so far, almost absolutely, is at least all the cases in the U.S. have quarantine at home. I
Yes.
don't think there's been any hospitalizations that I'm
Yeah.
aware of.
I'm not aware of any unless something's happened with an immunocompromised individual. To
Yeah.
my understanding, they're all quarantining at home.
All right, let's go ahead and switch gears a little bit to what's been going on since May. We're really seeing something different going on. And the people that I've been trying to find articles on and get their opinion are the African scientists, because they've been up to their elbows in monkeypox in Nigeria since 2017, and in the other countries for, I think DRC saw their first case in 1970 or something like that. And the Nigeria CDC said in a recent statement, they say that in their part of the world, there has been no evidence of any new or unusual transmission of the virus, nor changes in its clinical manifestation. And Dr. Rohde, I don't know. I don't expect you to have the answer to this, but I'm gonna throw it at you anyway. I've covered monkeypox for years, and what we're seeing in Europe, for example, with the MSM, I don't recall reporting that same scenario in Africa ever.
Yeah, I mean,
so I just want to get your thoughts on that.
When you asked me to come on and we kind of talked about, some of the points we might cover, that's probably one of the ones that's difficult, kind of difficult to get at. I think possibly part of it might be that in that part of the world, perhaps, and again, I'm just kind of hypothesizing here, perhaps that some of those cases that, have shown up in that part of the world, which you and I know have occurred, it's not new. We have seen monkeypox cases in those parts of the world, that we're just not seeing all the cases. It's interesting. I've read some of those articles too, and you'll see a little bit of irritation from that part of the world where they'll say, well, we've been talking about monkeypox for, 15 years, 20 years, and there wasn't any interest from the US or other people because we don't deal with it. It kind of makes sense. Right. And so I think they're trying to make a point that, here's another scenario that we've been watching this and we're a little concerned that it seems to be an endemic ongoing issue here, and there is potential for it to be transmitted. But I don't know. I don't know if there's low level, in those areas that have been non-detected, that we just haven't really documented, some travel history or other things going on that they've been talking about. So I'm not sure. I have found nothing in the scientific literature that really digs into that question that you asked. So it's a great question, and it'll be interesting if we see anybody trying to dig up, old patient specimens or archived materials, or see if we can find perhaps if something's been going on there in that part of the world.
Yeah, I can tell by the things I read that these scientists over there are scratching their head. It's like, what on earth is going on?
Yeah,
right?
I mean,
we don't see that here.
It really is. And again, I think that's what grabbed all the headlines. It really is, kind of a novel possible transmission route, even if it's not what we consider truly sexual in nature. But if those types of contacts are because people perhaps are more susceptible to it, or whatever the situation is. Again, I'm throwing in, we might be seeing more of it because we are better at diagnostics. There's all these other statistical interferences that we're not going to talk about here today, but certainly the clustering and the unusual patterns of lesions and pustules in those areas of the body certainly show a linkage to those groups. And so, if nothing else, we never thought about it in this way, and now we need to be concerned with respect to those types of practices.
You said you read the new CDC MMWR today.
Mm-hmm.
What did you get out of it? What new did you get out of it?
I really didn't get anything majorly new. It's a very good timeline from the first diagnosis in the U.S. on May 17th in the Massachusetts case rather, and kind of a walkthrough, including looking at the New York case. By the way, the New York case on May 4th was evaluated, and the person was treated for a presumed STI and sent home, and then it kind of progressed to pustules, and they came back, but all their testing has been negative to this point. However, the patient received a positive Orthopox test result at the New York City LRN laboratory and continued to isolate at home. So it was like this early false negative kind of stuff going on, and ultimately May 19th is when they really detected that. So anyway, that's kind of going on, and then they talk about the other U.S. states. So if you want to check out the MMWR, again, it's a great publication. If you're not familiar with CDC's MMWR, there's 9 states now that they're looking at: California, Colorado, Florida, Georgia, Massachusetts, New York, Utah, Virginia, and Washington. And up to now, they have reported 17 patients with confirmed orthopox virus infection. And so unless they rule them out, that's kind of where we're standing. Let's see. I think they mentioned my highlights here. They mentioned 14 of those 17 reported international travel involving 11 different countries during kind of that 3-week worrisome symptom onset. And 16 of the 17 patients were all identified as men who have sex with men. And so, there you go. We've been talking about it. And so the average age is 40 years. It ranges from 28 to 61. They all had rash between May 1st and 27th. 3 of them were immunocompromised. And so, again, I think the biggest thing I would say about this publication is it's a really well done timeline, in my opinion. And then they get into as you've heard me talking about, they get into the prevention, the treatment possibilities, the diagnostics, the vaccines if needed.
Yeah, we'll talk about that in a second. Yeah. I know today I also reported a case out of Philadelphia and a case out of Chicago. So
okay.
the numbers are continue to rise. But Dr. Rohde, again, I'm picking your brain on your thoughts. Why are the cases so geographically dispersed?
Yeah, the theory is that the clustering occurred within a particular group of these individuals, and then, as you just heard, all that international travel. And so that's exactly what they're doing right now, is they're mapping that travel to see if those clusters are because of travel contact.
Yeah. So that was kind of a give me.
Yeah.
Another question from Tiffany. She's keeping us on our toes here today.
That's good.
And she says, is there a treatment since it's a virus? Are hospitals equipped to handle a large outbreak? Well, let's go ahead and start with the treatment. Are there treatments available?
There are. And I think, you've mentioned this as well. There is at least one antiviral that is at least, I guess, tentatively approved. It's I may pronounce this wrong. I may mess this up. It's tecovirimat, T-pox. It was approved to treat smallpox back in the day. It's definitely orthopox antiviral. It interferes with the viral protein, so that seems to work for both oral and IV administration. It was approved for that in May of 2022, so really quickly they got that approved. And then there are, as we've talked about, there are vaccines, a couple of different vaccines that are FDA approved that protects against both smallpox and monkeypox. And interestingly enough, one of the questions I got on my articles was kind of this: hey, I'm 65 years old and I had the smallpox vaccine back in the 60s. Am I okay? And kind of my guarded answer was, well, you may have some protection, but it's been 3 to 4 decades since you had that vaccine. So you might respond a little quicker than say someone who hasn't had a smallpox vaccine, but I would still be, I wouldn't consider that total protection. You probably need a booster or need to be, watching for that. So the quarantine, I haven't really, I'm sorry, can you handle a large outbreak? I doubt all hospitals could handle a large outbreak, but I think we know so much about the virus, the transmission, the signs and symptoms, all the things we've talked about, that I think hospitals would rapidly pivot to being able to handle this, unlike a crazy virus like SARS-CoV-2 that's just out of control community transmission.
But even with the fact, though, that monkeypox is in almost every single case has been incredibly mild.
Right.
I mean, hospitals probably won't be affected at all.
It's
Right?
not. I can tell you now, it's not high on their priority list. They're
Sure.
still worried about COVID and other things that are going on.
It even, I think the World Health Organization came out past several days, maybe a week ago, I can't remember. And the pandemic potential of this is
pretty low.
Yeah, not a big concern.
Yeah, pretty low.
All right. Yeah, we definitely got to go over this, Dr. Rohde, because this goes hand in hand with any kind of new outbreak. What are some of the myths or false information that's being spread about monkeypox now that it's a household name?
Yeah, boy, we could do another show on this, couldn't we? Robert and I were talking before the show. I got an email today asking me to do an interview, and there is some information, as always, circulating in kind of conspiracy circles and other things about, patient zero perhaps might have been a lady in Pennsylvania who had a car accident with a truck, and this happened transporting, I think, about 100 monkeys to a research facility, and then she got sick, and she ended up going to the doctor and all this, but she was fine, everything resolved. She had none of the types of things you would expect, the pustules, anything like that. And then, unfortunately, I can't remember the timeline, but this lady did end up dying at some point. I think a few months later, and she was an elderly lady, but that has kind of taken off in some circles that this was some kind of cover up, and she was harboring the virus, and now it's out, and the government doesn't want to talk about it. And even though they've went back and kind of answered all the questions and put out the different fires around that, as once a story ignites, those fuses are hard to put out, and so that's off and running. And just in general, I've seen some of that, as you probably have. There's just kind of stories popping up, as you've mentioned, as clickbait that's out there that's troublesome, right? I mean, that's always the battle. In my mind, it's the ongoing problem in society is headlines that are inaccurate, and they're clickable for information, and they just go down these rabbit holes of conspiracy theories. And what's the saying? I mean, once the argument becomes circular, there's like no way to prove something. I mean, you can make anything up. It's always the onus of proof is on me, and no one ever wants to defend their conspiracy other than it's he said, she said. They have no data. It's just frustrating, I think, for those of us in public health and the medical lab when those sorts of things happen. But that's where we're at. And I think, again, that's why your show and others that are legitimate, outlets to provide this type of information, so that people aren't panicking and spreading misinformation that just becomes problematic.
Yeah, and, Dr. Rohde, there's another issue that's out there because of the high concentration of people that are gay men that are getting infected with this, that there's a resulting stigma that's going to come out of it. And reporting is key to this, because some people are irresponsible with their reporting.
Absolutely.
While others aren't.
Yeah, absolutely. If we didn't learn our lesson from HIV, I don't know what to say. I mean, HIV, same thing. It's something people didn't understand. and you start labeling and putting stigma on certain things, when, as we know now, HIV does not discriminate. It crosses all layers of society, and so can monkeypox. A virus, as we've talked about before, absolutely does not care who you are, how much money you make, what color you are, what culture you are. It only wants to infect, replicate, and move on. And that's what microbes do. And so until society can kind of understand that public health and these types of emergencies are not biased, it's tough to fight that battle. But that's the battle I'm trying to fight on a daily basis, to get communication out there and to raise health literacy, and hopefully we'll all be able to do that over the coming years.
Our friend Tiffany has another question. Monkeypox.
Go, Tiffany, go.
Yeah, I know. Lifelong immunity, or can you get reinfected?
My understanding is that you can get reinfected. It is a DNA virus. So, we haven't really talked about that. I mean, things like SARS and influenza and those types of viruses are RNA based, and RNA bases tend to mutate rapidly and change a lot. DNA viruses tend to be more stable and don't mutate as often. And we kind of talked about that in the pre-show. This one has shown some interesting things. There's been about 40 mutations that have been reported, and there's some hypotheses around that it's probably not the virus itself. Like, we think about viruses that mutate rapidly, like SARS-CoV-2, just out of control, RNA recombining and so forth, reassorting. But what most people are saying about this is that the mutations have happened because in the human system, we have a family of enzymes, and I jotted this down because I hadn't heard of it. It's ApoBec3 family. It's a group of human enzymes that interact with this virus, and it's a host, kind of a host mediated process. And so it's the body's immune system trying to protect itself from this particular virus. So there's some thoughts that it might be a host mediated process, or it might be the virus gets back into the animal population and kind of changes a little bit before it jumps back to humans. So there's some thoughts going on there. But my understanding is that you can be reinfected. But again, the mortality rate is relatively low. And while there is a vaccine, there's a couple that are effective. Generally, you're not going to get that vaccine unless you're working with the virus in a laboratory. You may use it in a preventative way if you're concerned about a group of people that have been exposed and you're trying to stop the outbreak. Veterinarians, just the type of people that might be interacting with rodents or other agents in certain parts of the world. You're just not going to just rapidly disseminate 300 million vaccines for monkeypox. It's kind of a waste of time and money.
Well, I have seen that a lot of some European countries have requested stuff from Bavarian Nordic. I think Europe, the US, and Canada all have the same vaccine from Bavarian Nordic, but they all have different names or whatever.
Right.
But I know Portugal and some of the other countries have requested vaccine and have got or are getting it. So
yeah, I think I saw, again, I might misquote this, but I think the US has ordered, I'm going to say 13 million for some reason. It's sticking in my head. Maybe it's just a just in case type of thing, but I mean, that's a very small percentage of the US population. 13 million sounds like a lot, but when you have probably 350 million people, it's a pretty small allotment.
Yeah. And I just looked at the CDC website, and they're saying there's 21 cases as of yesterday.
Okay. So our numbers changed that quickly. Yeah.
Yeah, but still, we're talking about 21 cases in a month, right?
Exactly.
Or so. Dr. Rohde, how can the outbreak be stopped?
I think it's going to probably be resolving on its own with all of the public health education and the monitoring of cases. I think it's going to probably be something we see die out over the next, hopefully, month or so. The only way I would see it continuing in any significant terms is if there is any type of interaction going on with these groups of individuals that either don't know about it, or they're not following the guidelines, or people aren't isolating at home like they're supposed to. I mean, in a scenario where we did start seeing maybe more clustering or more problematic issues, you might get out the vaccine and use it in certain situations to try to, cover certain population sectors or something like that. But I still don't see that happening right now. 21 cases in a month. Um, we have more cases of so many other illnesses on a daily basis that we don't, think about it that way. So I just don't see it happening
Do you
at the
think there's
moment.
do you think there's something going on different in Europe as opposed to North America? Because
With
the European countries have such higher volumes of cases. UK has 200, and
right,
right, and the only place in North America that has significant cases is Quebec. I think Quebec's got over 50 cases. Um, so, do you, do you think Europe is like just the epicenter, and we're getting travel associated ones
yeah. I mean,
primarily?
that's what I think. I mean,
Yeah.
based on the data, if you look at the epidemiological history of it, that tends to be what most people think. I mean, there are some different thoughts around it. I mean, when you think about Europe and some of those countries, it could be anything from culture, cultural behavior, cultural practices, protection, sexual protection might be different. I mean, I'm not, educated in those areas highly enough to make those types of statements, but perhaps there is something in human behavior that's a little different in those areas versus the United States. Or as you say, it's just that it's so sporadic because the travel piece is so limited that I mean, it's kind of interesting too, as travel's been so hammered, the last 2 years, that are we seeing these cases because now there's an explosion of travel to Europe? I just returned, as you know, from Amsterdam and Germany on a quick 2 week vacation, and I don't know, maybe there's such an increase of travel that we're seeing a little bit of a kind of a data point there that's showing a little bit of a rise just due to travel alone, just enormous increase in travel around the world versus even 6 months ago. And so now maybe this was happening 6 months ago and we just didn't see the cases as we do now.
Yeah, I just want to go back to what you said earlier about public health education, and I think this is really where we're in the U.S. So state health departments and the CDC just letting you know these are the risk factors. Avoid
Yep,
these risk factors, and this is going to go away.
that's right.
Right. I mean that's really their job in this case, right?
Absolutely. I mean,
Yeah.
again, I just plead for people to follow the science and to understand the types of information that are being put out, with the caveat that CDC has learned some lessons. I think they've learned some lessons, and the difference again between SARS and what's happening right now is that we know way more about monkeypox than we ever did about SARS-CoV-2. We were literally learning on the fly, and trying to learn around a virus that evolved so rapidly that you could say something one day and 2 weeks later you look like an idiot. And viruses, in my professional opinion, viruses consistently can make an expert look silly. And I'll say that going to my grave, that you just can't make black and white statements. You always are trying to have a disclaimer or kind of set your statement in a way that covers your bases, and then people get frustrated, right? They're like, "Oh, I need to know." It's like, well, we don't know. We don't know anything about this virus, and we still see,
Well,
long COVID being a problem. So I just think monkeypox is totally different. It's just
yeah.
oranges and apples.
Yeah, I agree. Let's just close out with this, Dr. Rohde. Any advice for people that may be watching that are concerned?
Yeah, I think exactly what you're talking about. If you're planning on traveling, if you're planning on interacting in any way that might have close physical contact, intimate or not, be aware of what's happening, right, in the world and in the United States. It's not out of control by any means that we think. 21 cases as of today, and seek information from your healthcare team or your personal physician if you suspect something strange is going on, and just stay in touch with public health information and all of the different information that's coming out with this kind of ongoing and unfolding event. I think it will be something that we're not talking about, by the end of summer. I think we'll be moving on, if not before then, unless it's a sporadic case here and there. I just don't think we're going to see anything of significant concern.
Definitely hope you're right. Thank you, Dr. Rodney Rohde, Texas State University. And again, I'll link to his articles, and I'll link to the CDC MMWR so people can check that out too. I haven't read it myself, so that's something I need to jump on. And Rodney, thanks for your expertise. Thank you, sir.
Outstanding. Thanks, Robert, for all your time, and thanks to your audience for participating. And I look forward to our next conversation.
Yes, sir. Take care.